So if you haven't got indigestion after the food, the dose of me in the afternoon could certainly provide some indigestion, especially to poor old Jerry, who's now sitting in the front there. So this is me in North Arkansas, trying to think clever thoughts, failing miserably, and having to go to Inspiration Point for some insight. And instead of seeing the green, watery valleys of the Ozarks, I saw a man who seems to have turned into a DNA molecule, and thought, well, perhaps this stuff can take us to the gene scene, and we can use genes to improve our knowledge of disease, because we know that mutations do happen, and they can be responsible for some very funny creatures in the world. And so the question is, if you go from the natural world to the world of cancer, what lessons can you learn? So you can look at the biology, and we understand how the kind of key players in this, the plasma cells, develop, and you should clearly target the biology. But what can you do with sequences? And so I think this is a very important slide, and it speaks to what Nupa was talking about earlier. Is the genetics of myeloma too complicated to understand? And the answer to that is clearly no. And there's been some good papers that come out recently, but it's all about passengers and drivers. So a bus is full of passengers. They look like the driver, but they're clearly not driving the bus. So for your myeloma, you should identify the drivers, and then if you targeted the drivers, you might kill the disease. And there's not likely to be large numbers of drivers. They only come down, on average in cancer, to about 6. So defining the important drivers of myeloma will take us to this next setting for the disease, which is personalized treatment. And so this is the current monolithic view. You've got myeloma, here's your treatment, have your induction, get your transplant or not, have your maintenance. Great. So it's not very clever, and if you look sideways into other cancers, they're starting to be very clever and leave us poor myeloma doctors behind by looking at subtypes of disease and the drivers, and then targeting therapy to the drivers. So what I'd like to think of is for us coming to a risk stratification approach, where you identify high-risk disease, treat it differently, identify extramedullary disease, plasma cell leukemia, treat it differently, define the initiating events, treat them differently, and so on and so forth. And so I think this is possible, and understanding the genetics will allow us to do screening, to develop new targets, to do targeted therapy, personalize the therapeutics, and monitor the response. So my talk in some way builds from this morning, and these are some of the groups. The 414 myeloma does seem to benefit from having lots and lots of exposure to proteasome inhibitors like bortezomib. High-risk states haven't really benefited from a lot of these new agents, and we need to find new ways of identifying these cases. P53 mutations don't really respond well to chemotherapy at all, and maybe we should treat these with immunotherapies. So lots of scope. So you might think of this as being the patient flow in the future. So currently we just see a patient, we do the bone marrow skeletal survey. In the future they'll get imaging strategies, they'll get biopsies, we'll know their mutation status, we'll segment them into different groups. Yeah. So you see them in the clinic, take the biopsy, send it off, get it back, see the patient again, reassess their status, personalise the therapy, and then set them off on a strategy of regular monitoring. And we are in this sort of setting, but I think it gets better as we go on over time. And so the MGP, this Myeloma Genome Project, is basically a global approach to try and put together all of the molecular data that is out there and to assemble it and analyze it. And so there's over 1,300 cases that have full data sets, nearly 2,000 where there's some part of the data set. So it's really an unrivaled set of data that people have given and allowed us to work on. And so we're going to move from this current status where you use these molecular tests to a much greater understanding of the DNA and RNA content of the tumour and use that to segment people. But it needs bioinformatics and big data. And so thank you for giving me the opportunity to make this slide. What you need is a bank of computers, supercomputers, but you need the geeks in the laboratory. And so you feed the geeks as much information as you can, and then you make sure they do as they're told and do the correct analyses. They press the buttons, and then you get good data that's really going to revolutionize things for patients in the future. And so this moonshot initiative comes into focus. So it's really all part of that continuum of data handling and big data, where if we can move more data into one place and get the geeks to analyze it, we're going to make real progress. And it all comes down to segmentation. And so what and how are you going to segment myeloma into groups that you treat differently? So how do you do that? So I think, while not completely at prime time, that these imaging strategies make a huge difference. And you can see such differences in disease on these different examples of a whole body DWIB examination. You can see some have barely any disease, some have extensive disease throughout the whole of their skeleton. And you can get more information about this by doing PET scanning, where the PET gets focused on a disease area and it shines out. So even the uninitiated can see this massive tumour that's taking up the tracer in the pelvis of this patient. And so you might ask, why do one? Why not do the other? But the answer to this is there are false negatives in the PET that the DWIBs will pick up. So you gain more information by doing both of the tests. And so you can also put needles into these lesions. And the point of this is that if you do one biopsy, she doesn't like it, but you do one biopsy, could be low risk. You have one of these lesions that are up here, that could be high risk. And if that site's high risk, your prognosis is going to be high risk. And so the deal for patients is that really having a good assessment when you first come along helps you long term, because you know exactly the type of disease, where the disease is. You then go back to your local doctor, have the majority of treatment delivered, and then perhaps go back to a centre for reassessment. This is just to show that last point. Then the risk stratification. Who has bad risk disease? It's very much a difficult thing to identify. And I've just been looking now at some of the groups. So high risk by the ISS strategy varies from 40% to 10%, and the median survivals vary from a year and a half to over 5 years. So it's not really helping you if, I've got high risk disease, but yeah, I'm going to live for 5 to 10 years. So it's important that we get better tests. And so the MGP is really shining light onto that. And so basically you can identify a group of about 7% of cases based on whether they have mutations in this gene P53 or whether they have amplification of a region of chromosome 1 that Faith showed you. So that's going to be a real step forward, because this group may be candidates for like CAR T cells when they're first seen. You don't have to wait until they get beaten up by the disease and relapse 3 times to receive it. So that's the real aim. You can also find new targets. And so this is the mutational spectrum, which I kind of don't expect you to remember. But if you look at this cartoon in the middle, RAS figures large. So you can target the RAS pathway, and there are targeted therapies. And even if you're beaten up with chemotherapy, a proportion of patients will respond to agents targeting RAS. So maybe sequencing is important, because then you could just target that pathway. If you don't have that pathway active, they don't work. So a big step forward. And I think Faith made the point about this 11-14 subset of myeloma who respond to venetoclax, something that targets the death or survival pathways in the cancer cells. So that's going to be a driver that forces some of this into our clinical space. And once it happens, you're going to see this monolithic viewpoint disappear, and targeted and personalized strategies will develop. And it's also clear, you take single agent daratumumab, only 30% of patients respond. So what is it about those patients, or the 60% that don't respond, who should get daratumumab? And the same will apply to CAR T cells. Who responds well to those agents? So the future is not going to be about monolithic myeloma. It's going to be about subsets, segments of disease, and personalized therapy.